In regards to the Healthy People 2020 initiative, we have chosen the indicator of suicide, more specifically veteran suicide, through an intervention we entitled Operation Shield. Currently, suicide is the 10th leading cause of death in the United States. From 2004 to 2014, the age-adjusted suicide rate in the U.S. increased by 18% from 11.3 to 12.93 per 100,000 population, moving the Healthy People 2020 objective of 10.2 suicides per 100,000 in the wrong direction. In 2014, it was estimated that about 495,000 people were hospitalized for self-harm related injuries, suggesting that for every suicide there were 12 people who harmed themselves. However, because of the way the data was collected, we are unable to distinguish between unintentional suicide attempts from non-intentional self-harm behaviors. Note that many suicide attempts go unreported or untreated, with surveys suggesting that there are at least 1 million people who engage in intentionally inflicted self-harm every year. Now looking at some more specific data, there are approximately 117 suicides per day. White males accounted for 70% of suicides in 2014, with middle-aged white men making up the largest subgroup. Adolescent American Indian, Native Alaskans account for the second largest group, and Black non-Hispanic population had the lowest rate at only 5.7 per 100,000. The ratio of suicide attempts to suicide death in youth is estimated to be about 25 to 1, compared to about 4 to 1 in the elderly. Men commit suicide 3.5 times more than women. However, females attempt suicide 3 times as often as males. Suicide rates varied also by age group. For example, 5.2 suicides per 100,000 population in persons aged 12 to 17, and 16.6 suicides per 100,000 among persons aged 65 years and older. Persons living in metropolitan areas had a lower suicide rate than persons living in non-metropolitan areas. Notably, in 2014, the state rankings for suicide, Montana was number 1 at 23.8 versus New York, which was number 50 at 8.09. A reason for the high rate of suicide in non-metropolitan rural areas is possibly due to more social isolation and less access to mental health services. A resident of Montana may live in a town with only 6 people and may be separated by miles of rural landscape, whereas a resident of Manhattan may live with several hundred people in one apartment building alone. Social relationships and the size of an individual's social network can be a risk or a protective factor for suicide. Veteran suicide has gained more attention in recent years due to social media campaigns and awareness raising. However, more needs to be done to help stop this growing problem and to protect our nation's veterans who sacrifice so much to ensure our safety. According to statistics from the Department of Veterans Affairs, veterans constituted only 8.5% of the U.S. population, yet accounted for 18% of suicide-related deaths in 2014. And after adjusting for age differences, the risk of suicide was 18% higher among male veterans and 2.4 times higher among female veterans as compared to civilian adult males and females. About 65% of all veterans who died by suicide were age 50 or older. An average of 20 veterans die by suicide each day. However, only 6 of the 20 were users of VA services. A possible reason for this is that veterans are assigned priority groups by the VA that determine their eligibility status services. Eligibility is largely based on service-connected disability level income, those with a higher rated disability level having priority. Due to changes in the rating system over the past decade, the proportion of veterans with a 50% or higher service-connected disability has more than doubled, increasing from 11.7% to 25.9%. Although this places many younger veterans in a higher priority level, therefore giving access to more immediate care, it presents a problem for older veterans who compose the highest rate of suicide and that they may have more of a longer wait for treatment. Further compounding this problem for older veterans is that in the past, mental illness was not as recognized as much as it is today, or was left untreated largely in part due to the stigmatization or the lack of physician knowledge on how to recognize it. This left a lot of veterans suffering in silence and may be a potential reason why there is such a disproportionate number of suicides with veterans over the age of 50. For purposes of this intervention, we will be focusing on Palm Beach County, Florida, which is home to one of the largest veteran populations in the state of Florida at approximately 73,000. Since it would be unethical to apply suicide intervention to only a certain segment of the veteran population while denying other veterans a chance at obtaining help, we won't be focusing on a specific age, gender, ethnicity, socioeconomic status, but rather the population as a whole. In order to learn more about the needs of veterans in Palm Beach County, we will partner with the local VA in West Palm Beach in order to gain insight into the services offered, types of cases, data related to mental health disorders and suicide rate, as well as any other information that can be provided. We will work with local hospitals and drug rehab clinics to find any additional information for veterans who don't utilize VA services. And we will also send out surveys to veterans and create focus groups to gain insight into the perceptions of the availability of services, current mental health status, feelings or experience with suicide attempts, or suicidal thoughts. It has been suggested that veterans are at a high risk of using suicide as a means of relieving suffering that may result from combat-related PTSD and depressive disorders, as well as issues relating to issues like unemployment, financial stressors, and marital problems. Military service members who have served for many years are also used to living a structured lifestyle where they are provided with housing, food, and daily direction. Leaving the military can create anxiety and a loss of purpose, as some don't know how to function in the civilian world. Veterans often do not seek proper mental health treatment due to an attached stigma of considered being weak, not recognizing mental illness, or simply not knowing where to go for timely treatment. These are just some of the suggestions or rationale behind veteran suicide. However, we need to analyze all of the possible contributors in a more depth according to each level of the social ecological model in order to discern the risk and protective factors which we can then utilize to plan the intervention. Beginning at the interpersonal level, we must look at individual factors of the veteran that may ultimately lead to behavioral intent of committing suicide. To do this, we will use components of the theory of planned behavior. Behavioral intention is the single most important aspect of the theory, which indicates that if a veteran has the intention to commit suicide, depending on influences of their attitude and control beliefs, if the veteran's judgment about the outcome is positive, or in this case they feel that ending their life is a better option than staying alive, and if the veteran believes that committing suicide will be easy and that they have control, then there will be strong intention to follow through. At the interpersonal level, we will be focusing on behavioral beliefs, attitude towards the behavior, as well as control beliefs and perceived behavioral control and how they lead to behavioral intention. At the interpersonal level, we will focus on normative beliefs and subjective norm as it leads to behavioral intention and eventually the behavior. That's something we'll talk about a little later on. Some possible risk factors at the interpersonal level may include major depressive disorders, poverty, feelings of loneliness, a view that suicide would provide relief to suffering, low perceived barriers and high self-efficacy to committing suicide, hopeless attitude, inability to adapt to civilian life, as well as personal tragedies that trigger depression. Possible protective factors at this level include knowledge and skills to seek help, awareness of unhealthy disposition and unclear thoughts or perceptions, attitude, biological and psychological disposition, as well as adaptability and resilience. The interpersonal level of the social ecological model consists of social network and social support systems, including family, work group, and friendship networks. This is especially important since epidemiological studies have consistently found a correlation between social relationships and causal effects on health, and therefore an intervention should encompass all aspects of an individual's interpersonal relationships, family, friends, peers, and quite possibly professional relationships such as coworkers and medical providers. Furthermore, utilizing the idea of interpersonal social networks is important since it gives rise to various social functions such as social influence, social control, social undermining, social comparison, companionship, and social support, therefore making it more likely for a move towards behavioral change. The construct of subjective norms from the theory of planned behavior is useful at the interpersonal level in that it would help create understanding of the veteran's perception of how others view suicide, which may have a major impact on influencing intention. The veteran may have the attitude that suicide is a viable option and they may believe it will be an easy solution to their suffering, but if they feel strongly about others' opinions and how it would affect the lives of their friends and family, it may be enough reason to want to stay alive. Conversely, if a veteran has strong feelings of loneliness or absent social support, it may be the initiator that fuels behavioral intention to commit suicide. Assessing the social networks of veterans is important at this level in that it can help us direct messages and identify communication patterns, therefore allowing for a much more effective social marketing approach during the intervention. It will also help us to be able to target similar individuals and subgroups who we can bring together to create a community support system for those veterans who feel isolated and have little to no social relationships. Possible risk factors at the interpersonal level include poor quality of social relationships, marital problems, feelings of lack of support, isolation. Possible protective factors at this level include strong social relationships, family bonding, identifying with a specific peer group, and social status. The organizational level includes social institutions with organizational characteristics, and formal and informal rules or regulations for operation. Organizations can sometimes act as a barrier or facilitator for veterans seeking treatment, so that is why it is important to include them in the social ecological model. Through the use of the diffusion of innovations theory, organizations will be instrumental in creating awareness about veteran suicide and helping people overcome the stigma about mental illness and seeking treatment. Leaders and educators need to be identified and trained to conduct classes and spread awareness about suicide prevention, and organizations such as the VA and local medical facilities need to be involved in order to implement new policies and practices that encourage the adoption of treatment-seeking behaviors. Some possible risk factors at the organizational level include a lack of organizational support, lack of awareness, and the fact that some of the organizations may be profit-centered. Some possible protective factors may be organizational climate, bonding to the organization, level of facilitation for healthy seeking behaviors, as well as some organizations being more employee and member-centered versus profit-centered. The community level of social ecological model includes relationships among organizations, institutions, and informal networks within defined boundaries. According to Glanz, a community organization is important in health education and promotion because it reflects one of the most fundamental principles of starting where the people are. Using the key concepts in community organization and community building, empowerment, critical consciousness, community capacity, social capital, issue selection, participation, relevance, allows for a multi-layered approach that can build a sense of community and lead to greater participation, individual coping capacity, as well as health behaviors and health status. By employing a CBPR approach, we can engage the veteran community more effectively while also providing purpose, empowerment, and providing job opportunities. Veterans will be more trusting of other veterans who they can identify with, thereby leading to both a higher retention and recruitment rate and subsequent program effectiveness. Some possible risk factors at the community level may include a lack of awareness or mobilization, social norms, as well as a lack of resources. Some possible protective factors may include a desire for healthy community, social bonding, as well as healthy beliefs. The policy level of the social ecological model consists of local, state, national laws and policies. Working with policymakers who can affect change by helping to remove barriers while simultaneously opening more avenues for treatment for veterans will be important since it will have a trickle-down effect to the other levels of the social ecological model. For example, the issue regarding eligibility status off awarded level of service-connected disability needs to be addressed at the policy level. If older veterans don't have equitable and timely access to care as younger veterans, then this will remain a barrier that contributes to the higher number of suicides in that age group. Policies need to be amended and modified that will enable the quickest and easiest route to treatment, while also not creating a financial burden for veterans. Some possible risk factors at the policy level include a lack of funding, a lack of policies, inefficient systems, rules or regulations, or a lack of awareness from legislators. Some possible protective factors include adequate funding, adequate program or services, level of commitment, and empathy from legislators. Our intervention will utilize a CBPR approach where we will create a community academic partnership consisting of veterans with and without history of mental health disorder and treatment, PTSD, substance abuse, and suicide attempts, organizational leaders from the VA, psychologists, therapists, and other mental health workers, stakeholders from the funding organization, members of the Chamber of Commerce, as well as local community leaders and members from various veteran military-related services or organizations such as the USO or the American Legion. Community members will be involved at each stage of the process, including the research, planning, implementation, analyzing, and dissemination of data, as well as evaluation. The intervention will focus on addressing or removing potential risk factors while enforcing or creative protective factors at each level of the social ecological model. We will ensure effectiveness through pre and post surveys and data collection, as well as from independent data obtained from the VA and CDC regarding suicide rates and any changes in number of veterans seeking treatment. We will train veteran partners to conduct focus groups and interview participants, since there will be a level of trust that won't exist with a non-veteran interviewer. From this, we hope to gain a better understanding of a wide range of topics, including things such as veteran perceptions regarding access to treatment, attitudes, self-efficacy, beliefs, social interactions, in order to inform and direct us to better create interventions at the intra and interpersonal level of the social ecological model. The methods used at the interpersonal level will include disseminating information through email, social media, brochures, and informational meetings at the VA. Information will focus on overcoming the erroneous or negative beliefs discovered in the focus groups and surveys as they pertain to the theory of planned behavior framework. Questions may be presented that initiate critical thinking and cause reevaluation of self and the environment, and get the veteran thinking about all the consequences of suicide, including how it will affect those around them. The idea that getting help makes someone appear weak will have to be addressed, and information on overcoming barriers to getting that help will have to be provided. A media campaign will be used to provide phone numbers that veterans can use when they do need help. It will be posted on billboards, placed in advertisements, posted to social media, and provided in pamphlets to essentially drill the information into memory so that they won't forget. If an issue is discovered that veterans don't know where to turn for help, this will hopefully provide a solution, much like when commercial advertising pushes a product onto consumers through a heavy marketing campaign. At the interpersonal level, social media campaign will target family, friends, and peers of veterans in order to actively engage, educate, and create awareness for recognizing potential warning signs of suicide. In this manner, involving social networks will create effective change on the interpersonal level of the social ecological model by fostering a support system for the veteran, which may lead to a more positive, subjective, normative views from the theory of planned behavior. At the community level, we will hold a number of events aimed at increasing awareness of veteran suicide prevention, broadening social networks, and mobilizing the community. These events will be centered around recreational activities that veterans may like to engage in, such as paintball, barbecues, fitness events such as mud runs and marathons, as well as firing guns at the range, while also educating, providing resilience training, as well as contact information for mental health services. Through the inclusion of family members and friends, and by introducing veterans to new contacts, this will also address the interpersonal level of the social ecological model by helping to eliminate social isolation while strengthening current support networks. Furthermore, this will also address the community level through mobilizing the community to come together and utilize its resources. At the organizational level, curriculum will be developed by our community academic partners, seminars to be administered to organizations such as the VA, local medical facilities, as well as employment agencies and the Chamber of Commerce, in hopes of creating awareness about veteran suicide, a network of support systems, as well as increasing training and job opportunities that will provide both skill and purpose for unemployed veterans. Creating or enhancing awareness may remove some of the risk factors while also enforcing protective factors such as organizational bonding. Lastly, the policy level of the social ecological model will be addressed through working with the VA or federal legislators who are also involved with the VA policy by trying to change the current system and provide equitable access to mental health services for older veterans regardless of disability rating. Additionally, to address the issue of slow wait times and saturation of VA services, we will try to work with state and our country legislators to either increase funding or alternative suicide prevention centers to create new suicide prevention centers or services that can handle overflow from the VA, or be placed strategically in areas where veterans can easily access them when VA services aren't obtainable due to geographical distance. Palm Beach County is one of the largest counties in Florida with only one VA hospital in West Palm Beach. A formative evaluation will be conducted during program inception all the way through the implementation phase in order to help ensure that our program has been conceptualized and developed appropriately. Evaluating the knowledge, skills, abilities, strengths, and weaknesses of our internal staff and external partners, as well as using cost-benefit analysis, will allow for a proper assessment of our capacity and resources available to implement the program. Even more importantly, ensuring that the consumer orientation or the degree to which programs are adapted and adequately address the values, wants, and needs of our priority population will help ensure that the program is more readily accepted early on. Based upon feedback from partners and participants through the collection of data and questionnaires, necessary adjustments to the program will be made in order to achieve better adherence and outcomes. The concepts of recruitment, reach, and response relate to program promotion and help ensure that an adequate number of people are participating and that the program is being communicated effectively via the proper channels. Finally, interaction and satisfaction will help determine a level to which practitioners effectively work and communicate with participants, as well as how satisfied participants are with the program components. Understanding program effectiveness and participant satisfaction will help provide recommendations for adjustments as well as inform future applications of the program. Our goal with Operation SHIELD is to create an intervention that is successful in helping reduce the number of veteran suicides in Palm Beach County through the application of behavioral theories and tailored interventions at all levels of the social ecological model. We believe that we must engage, empower, and mobilize the veteran community through the use of CBPR techniques and principles in hopes that they will not only effectively contribute to combating the growing problem of veteran suicide, but ultimately will contribute on a much larger scale to the goals of the Healthy People 2020 initiative and reducing the national suicide rate.